Next, I'd really like to interview, actually, not introduce. I would like to interview him as well. Ricardo Dolmetsch from UniQure, who is the president of R&D at UniQure, and he's going to tell us about the UniQure gene therapy program. Thank you.
Great. Well, first of all, thank you so much for the opportunity to present, and that's going to be a very tough act to follow, but I'll do my best. So today I'm going to give you an update on AMT-130, which is our gene therapy for Huntington's disease. So AMT-130 is a modified AAV5 viral vector that contains a microRNA that targets exon 1 of the Huntington gene. It has been optimized so that it is highly specific. It uses what we call our UniQure technology, so it doesn't have an off-target strand. And in preclinical models, in pig models, it very efficiently lowers the expression of both full-length Huntington and exon 1. So it is injected directly into the striatum. It is a surgical treatment. It is administered using 3 stereotactic injections that are delivered on each side into the putamen and the caudate using convection enhancement. We monitor this using real-time MRI, which we include gadolinium. This is sort of what it looks like during an administration. We can actually watch the filling of the structure. Whoops, there we go. Okay, so at the moment we're studying AMT-130 in 2 ongoing clinical studies in the US, the EU, and the UK. So HD Gene TRX1 is our US study. It is a double-blind, sham-controlled trial. So far we have completed 27 procedures in 26 patients. That's because 1 patient has crossed over. These are 16 drug and 10 sham surgeries. We have 2 cohorts, one administering a lower dose of the drug, which I should just point out we still think is going to be, or at least has a potential to be effective. We're administering 6 e to the 12th genome copies per patient. And in that first cohort, we are treating 6 patients with a drug and 4 sham. And then we have cohort 2, which is a high dose. We're administering 6 times 10 e to the 13th, and that's 10 patients on drug and 6 controls. And then in addition to this, we're planning a 3rd cohort to optimize the surgical procedure. At the moment, the surgery takes approximately 1 day, and we'd like it to be a little faster than that. In the EU, it's an open label study. Again, we're treating patients with both the low dose and the high dose. So this is kind of the schematic of the study. First of all, the inclusion criteria. So patients have to have more than 40 CAGs, 25 to 65 years of age, a total functional capacity between 9 and 13, so still very functional, DCL level of 4 if they are motor manifest, or 3 if it's sort of multidimensional. And then for us, it's very important that they have a minimal putamen volume. So our minimum volume is 2.5 cubic centimeters per side, and the caudate volume is greater than 2 cubic centimeters per side. And this is important both for the safety of the surgery as well as because we'd like to be able to preserve neurons. The way the actual study works is that there's a screening visit where we make sure that people are eligible, and specifically that they meet the criteria for striatal volume. This is then followed by a baseline visit. The surgery itself takes 1 day, and in the US, the patients go home the next day. In the EU, they often stay a day or 2 in the hospital. And then this is followed by a blinded follow-up, initially at 14 days, then at 1 month, then at 3-month intervals for 2 years, and then a follow-up up to 5 years. So of course, for gene therapies, it's a one and done therapy. We administer it once, and once you're dosed as far as we can tell forever. So what are we measuring? again, we're measuring biomarkers, so neurofilament light chain, which gives us a sense for neuronal health, mutant Huntington. Radiographically, we have volumetric MRI as well as MRS. And then clinically, we're looking at the total motor score, which is what we hope will have a biggest impact on the total functional capacity, of course, and then some measures of cognition like the Stroop word test, the SDMT, the symbol digit modality test, and HD-CAB, which is an assessment of emotional and psychiatric symptoms. Okay, so let me just give you an update on the first cohort. This is the initial demographic data. So generally speaking, the patients are well matched between the sham and the low dose. And again, this is a very, very small number of patients. So let's please bear in mind that this is just very preliminary, mostly for the community. They're well matched both in terms of age and sex and CAG repeats, as well as CAP score and total functional capacity and total motor score, as well as DCL. What does the safety look like? So far in the low dose, we haven't had any ADRs or SUSARs. We did have 2 severe adverse events that were both unrelated to AMT-130, but related to the operation, and they were both in the perioperative period. One patient had a deep venous thrombosis in the upper arm, which was resolved with anticoagulants, and another patient had a transient postoperative delirium, which was resolved with supportive care. We have had 95 less severe adverse events that were unrelated to AMT-130. The most common adverse events are, of course, procedural pain, procedural headache, post-lumbar puncture syndrome, and some other complications from anesthesia like fatigue and leg spasms. Now, I just want to stop for 1 second and give you a safety update on the high dose. We haven't actually yet collected or disclosed any data on the high dose cohort, but we did recently report that there were 3 severe unexpected adverse events that seem to be related to the drug in the high dose cohort in Europe. We've already dosed 10 patients in the US, and we've dosed 4 patients with a high dose in the EU, and we have 3 SUSARs. And in general, these have a couple of things in common. They're associated with striatal symptoms, including euphoria and repetitive movements, and headache and nausea in 2 of the 3 patients. And then there was by MRI, there was transient edema in the striatum of 2 patients. Again, all of this was observed within the first 14 days, and all cases, all 3 patients are now no longer hospitalized. 2 of the patients have completely recovered, and 1 patient has substantially recovered. 1 of the 3 patients was treated with steroids. Because of this, we're not on clinical hold with regulators, but we have decided to take a moment and just reassess all the data on both the low dose and the high dose to make sure that we're doing the right thing. And so we are collecting data. We will meet with our Data Safety Monitoring Committee later actually in October, and then we will make a decision as to whether we continue dosing patients with the high dose or the low dose. Generally speaking, we feel that these symptoms are manageable and they seem to resolve, but this again is something that we need to look at very carefully. Now let me just go back to what we know about the low dose cohort. Again, I just want to reiterate, this is from a small number of patients. So the first thing we looked at was neurofilament light chain. And what you can see, and these are the solid lines are the dose patients, and the dotted lines are the shams. So remember, the shams don't actually get anything into their brain. They just have a sham surgery, but nothing is actually administered. What you see is a big increase in neurofilament light chain that peaks at 1 month and then declines over the course of about a year. In 3 of the 6 patients, it's actually below baseline. But maybe the other thing you should notice is that the shams are also not increasing. So while we're very encouraged that the initial peak in neurofilament that is known, it's a known side effect of surgery, is returning to baseline, we can't really say whether the NFL is decreasing. And of course, we will know as we look at these patients longer. This is what the average looks like. So the average, the NFL is still a little elevated at 12 months on average, though, as I said, 3 of the 6 patients are actually below baseline. So what does mutant Huntington? Again, we're looking at mutant Huntington as a way of looking at target engagement. What you see here is the average in the orange. Please check out the error bars here. Again, you can see that over time, it looks as if we are reducing mutant Huntington in cerebrospinal fluid. The dark blue bars are the control. Again, this, of course, is the % change of mutant Huntington on the y-axis and time on the x-axis. And you can see that it looks as if it was sort of increasing, though the error bar is large, and then there was a sudden decrease. So why? And the answer is this. Again, the data is really quite variable. So while the dose patients all seem to have a general decrease in mutant Huntington and CSF that peaks at around 50% or so, the sham patients, mutant Huntington was actually very, very variable. And you can see that there's one patient in which it declined, another in which it clearly increased, and a third one in which it increased and then it declined at the end. We don't really understand why this is the case. But again, at least part of it is that there aren't very many patients. Okay, let me just summarize what I've told you. So first of all, the baseline demographics are comparable between the treated and the control groups, at least in this low dose cohort. AMT continues to be well tolerated at the low dose in treated patients. So there have been no adverse events in this population, but as I said, there have been 3 adverse events at the high dose. The NFL in the cerebrospinal fluid has increased as expected following the surgery, but then has declined and is nearing baseline at 12 months. And then I would say, and of course my job here is to present things as optimistically as possible, I would say that the trends in CSF mutant Huntington are consistent with target engagement at the low dose. We are actually quite encouraged that those error bars are pretty low, and basically in all the evaluable treated patients, the mutant Huntington levels were much lower compared to baseline at all time points. And the decrease of 53% was much greater than we expected because, of course, we're dosing the gene therapy straight into the striatum, and the mutant Huntington in CSF is a product of the entire brain. In general, in the controls, the data was much more variable. There was sort of an increase, and there seems to be a difference, but again, it's too early to tell. So with that, let me just thank all the people that made this possible. None of this would be possible with our PIs. This is them. And in addition to this, of course, it would not be possible without just the very brave patients who have volunteered for our study and their families, and we're extremely grateful for their help. So thank you so much.
Perfect timing. Question. One question. Great. Over here. Microphone over there. It's good you're wearing a bright shirt so I can see you. Great.
Hi, Ricardo. So my question is the following, is that did you measure the total Huntington or the wild-type Huntington in your assay?
Yeah, so those measurements we did. Well, not wild type, I don't think we have a good assay for that, but we have a good assay for total Huntington. And I think our conclusion was that the total Huntington measurements were too noisy for us. I mean, they didn't actually meet our kind of quality control, which is why I didn't show them. The mutant Huntington assay seems a little bit more reliable, but the total Huntington, at least in these small patients, was not interpretable.
Thank you.
Okay, and we'll come back and have more questions in the panel discussion. And we may